Good evening, everyone, and welcome to today's webcast, More Than Skin Deep. My name is Corinne Pettit, and I will be your moderator for tonight's presentation. Before we get started, we'd like to go over a few items on how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. This means if you can hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address as many as possible at the end. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. The National Psoriasis Foundation is the world's largest nonprofit patient advocacy organization dedicated to psoriasis and psoriatic arthritis, and we serve as the voice for millions of Americans who are affected by these diseases. Our mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. In order to move our mission forward, we engage thousands of volunteers around the country in activities that will lead to a cure. For more information about these opportunities, you can log on to our website after today's program at www.psoriasis.org. I would finally like to thank our presenting sponsor, Eli Lilly, and our national sponsors, AbbVie, Novartis, Celgene, Janssen, and Sun Pharma. Today you'll be learning about recommended treatment goals. This includes how these goals impact treatment options and risks associated with other health-related conditions, options for managing your symptoms, and strategies for working with your provider. Now I'd like to introduce our speaker, Dr. Benjamin East. Dr. East is a board-certified dermatologist with Baker Allergy, Asthma, and Dermatology, where he specializes in treating a variety of skin diseases, including psoriasis, using the latest technology and treatment options. He's also a clinical investigator with the Oregon Medical Research Center, where some of the clinical trials focus on current and emerging treatments for psoriasis, psoriatic arthritis, hair loss, fungal infections of the skin or nails, and pharmacokinetic studies and more. Until recently, Dr. East had a clinical practice with the Dermatology Department of Health Partners Specialty Center in Minneapolis. Prior to that, he was the Director of Medical Dermatology at OHSU and the co-director of the OHSU Center for Excellence in Psoriasis and Psoriatic Arthritis, which is a multidisciplinary clinic for people with psoriasis and psoriatic arthritis. The National Psoriasis Foundation is honored to introduce Dr. Benjamin East, who will introduce you to treatment goals and options.
All right, thank you. And thanks to everybody who's listening. There we go. Okay, so I have a few disclosures. I've acted as a consultant for a few pharmaceutical companies, and I've been an investigator with many that do focus on psoriasis and psoriatic arthritis. So I have familiarity not only as a prescriber but as an investigator with many of the older and the newer molecules that are available to treat psoriasis. And hopefully I'll be able to bring some enlightenment to you today. And so just to reiterate, we're going to talk about this new concept called treat to target, and sort of lead off with that, which may hopefully begin a discussion, if it hasn't already, between you and your dermatologist or your rheumatologist or your primary care provider, and perhaps change the way not only you, but providers think about treating psoriasis and psoriatic arthritis. And then we're going to go into more detail on the actual treatments. Again, touch on some of the older treatments available, and then highlight the newer products. And it's an exciting time because many of these are now incredibly effective and very safe. And then we'll talk about some of the comorbidities, so things that also go along with skin disease that you should be aware of and physicians should be aware of. And then wrap up with some of the lifestyle modifications that may help psoriasis. So this is a concept slide. So when we when we as dermatologists sort of think about categorizing people that suffer from psoriasis, you have to have some kind of goal in mind, and in order to have a goal, you have to have something to measure by. And so over the years, people have decided that the size of somebody's palm represents about 1% of their own body surface area. And you can use that then as sort of a measurement of how the how the psoriasis affects your skin. And these are somewhat arbitrary numbers, but we've classified mild psoriasis as anyone that has 3 palms or less of skin psoriasis. And then the moderate category is between 3 and 10% of your body surface area involved. And then if you have more than 10 palms covered in psoriasis, you're in a severe category. The caveat is that this is not a hard and fast rule, and it certainly needs to be modified depending on where the psoriasis affects you. So if you look under that severe category there, if you have psoriatic arthritis, you may have a very small amount of psoriasis on your skin, but your quality of life and your ability to do what you want to do on a day-to-day basis could be severely affected. So you're still severe. If you have your scalp or your face, if you have your palms and soles, if you have your genitals involved, those are areas that have a big impact on your quality of life. And even if you have overall a low percentage of body surface area, those are still severe severe issues. But it gives you something to think about. And again, this plays into this idea about what are we trying to accomplish with treatment. And so this was a group effort between dermatologists on the medical board of the National Psoriasis Foundation, as well as dermatologists and other practitioners in the community and patients. And the consensus was published last year, so this has been around almost a year now. And these are treatment goals, and again, it's referred to as treat to target. This concept may or may not be new. It started around issues like hypertension, high blood pressure, and it's being used now in rheumatoid arthritis, and it's being used in diabetes. And the easiest thing I can sort of explain is when you think about blood pressure, everybody knows that your ideal blood pressure is 120 over 80 or lower, but that's a target, right? So if you go into your primary provider and you have high blood pressure, they're going to say, well, we're going to start XYZ medication, and we're going to try and get your blood pressure to where it's 120 over 80. And if you reach it, there's your goal, and your treatment has been deemed a success. And so it's a similar concept to if you're a diabetic and you have a hemoglobin A1C level. That's a target that you can try and reach, to lower your A1C to a certain level. So other specialties are starting to adopt these goals, goal-based approaches. And in psoriasis, it was decided that there should be a goal. And so this is the first that's been published, and the first kind of treatment in dermatology for any skin issue, and definitely in psoriasis. And so the agreement was that what you should try and do with any new treatment you're starting for psoriasis, that your goal should be to get to 1% of your body surface involved or less, and that is considered a achievable and manageable amount of skin involvement. And when you have that goal in mind, the other part of that is to have a set timeline to say, if I want to reach this goal, when do I do it? How quickly can I do it? And many of the treatments that target psoriasis, the caveat with this is that these are generally older treatments. Some newer treatments actually work quicker. But in general, the consensus was that about 3 months of using anything, you should be at that 1% goal or getting towards that goal. I could show you over here. So this is as if you're starting out here in a bigger target. You're aiming for the 1%. At about 3 months, you may be, half of the time you may be close to 1%. Some of the time you're not quite there yet. and by 6 months, hopefully you're hitting the bullseye and you're down to really 1%. So this is it's a goal that you can have in your own mind, and it's a way to start a discussion with your physician to not just say, well, I just want to be better. Let's try something and see what happens. And then maybe 6 months or a year later, you come back in and you're still not to that 1%. And this is it's a different framework to start discussing how you should be aiming to improve or not improve. And it gives you an idea that if you're not improving at 3 months or 6 months, or if you're you're going backward or something, then it's probably time to switch therapy. So again, this is not a hard and fast rule. It's more of a concept, and it's a way for both patients and physicians to start talking about what they want to get out of treatment. So it's a collaborative effort, and that's really what it should be. So again, the goals of this treat-to-target therapy is that you want to know what you should expect when someone prescribes something for you. How quickly should you expect results? What is considered a good or appropriate level of improvement? And to speak on that question, based on other health issues, how severe your psoriasis is, there's, that endpoint may be different for different individuals. But the idea that you should be progressing towards clear skin is what you want to emphasize. And then again, at what point do you decide that this is not working and something different or something additional needs to be added to your treatment? So, and again, these are not guidelines. They're different ways to get to this endpoint, but it's a goal. So hopefully that's something that it'll be utilized by you, and it's also going to be utilized more by providers. So treatment decisions and goals, again, they're based on many things, and that's why it's hard to, on an individual basis, everybody's unique, and the response to these different approaches is all unique too. And so when you're dictating a therapy, you had to be cognizant of these various issues in any individual. So where the psoriasis is located, again, how severe it is it a pustular variant, which can be harder to treat? Are there other health issues that may complicate treatments? What are the side effects? What are the long-term issues when using medications? So if you use something topical on your skin, the risk may be pretty low compared to some of the older systemic medications. Or if you use light treatment, what's the risk of getting skin cancer? Things like that. Cost, insurance coverage, access to actually getting these products prescribed is always an issue. Everybody has different preferences and goals as well. And then there's special situations, of course, if you're a young individual or if you're pregnant or trying to become pregnant, you have to take those into consideration. So to summarize, the treat-to-target thing is it's a framework to help work in conjunction with your provider to identify goals and a plan, helps communicate. Again, this doesn't exclude treatments. Any treatment, is an option, and you're treating to try and get to clear skin. Everybody's unique, and it's the first step on an ongoing effort to improve your health. So let's move on to the actual treatment options, and we'll go through some of the older therapies and topical therapies and move on to some of the new exciting developments. So mild to moderate psoriasis classically is thought to be something more manageable with topical preparations and sometimes light treatments. Topical preparations have been around forever and can work well. The big limitation, of course, is that you have to actually rub these on your skin. You have to do it quite often usually. Most prescription topical products are prescribed once or twice a day, and it usually takes you several weeks to get improvement or clear skin. And the other potential limitation is you're waiting to see where the psoriasis is going to be as opposed to preventing it from showing up. And so when you move on to something that's systemic, you have the potential to really to shut down the inflammation that's going to show up on the skin. Whereas these older approaches tend to wait till you're actually breaking out and then go after the skin inflammation. And so most people are aware of a lot of these things. There are plenty over-the-counter products, tar, salicylic acid, medicated shampoos and lotions, preparations that try and remove the scale, the dead skin, to calm down the itch. And these could have benefit, but usually they're not a sole approach. They need to be used in conjunction. The topical products, several vitamin D derivatives, several vitamin A derivatives. These primarily affect the way the skin matures and lacks the ability to shed correctly and helps to regulate that process. So they target mainly the skin itself, not often the underlying inflammation. The mainstay for topical therapy is still topical steroids or corticosteroids, and these shut down inflammation in the skin locally, and they blunt the immune response that's driving the inflammation. So they tend to be the most successful, especially as you use stronger preparations. But they also have more limitation than the other products, mainly that continued use can lead to thinning of the skin, easy bruising, sometimes excess hair growth in the areas. And some of these, if you use the same, especially a strong topical steroid for years, you'll actually permanently cause these issues. So that's a limitation. Some of the more recent things are combination products. There's a slide coming up on a product that's in late development, will hopefully be on the market and offer a new approach. Phototherapy has also been used for millennia to treat psoriasis. We do it a safer approach now than natural sunlight, which has a risk of skin cancer and aging and sunburn. Most dermatologists nowadays use something called narrowband ultraviolet B therapy, and this is a very effective wavelength of ultraviolet to clear psoriasis and very safe. It's a time-consuming process. Anybody who's been through this knows you have to come into an office 2 or 3 times a week for several months, and there's usually a maintenance phase after that. But again, this lets you treat large areas of skin at a time, and most, if not many, patients will actually do very well with light therapy. There's a product called the Excimer laser. This is a narrowband ultraviolet B laser, so it delivers the same wavelength. It's very good for areas like the scalp, where the hair often prevents the full body light therapy from penetrating well, so the laser can be used on the scalp. It's good for tough to treat areas like the palms and soles. It can be used for residual, resistant plaques. If you're on, say you're on a biologic drug and everything clears except for your knees, you can use the Excimer to go after those resistant areas. It's also time consuming. It's usually twice a week treatment for several weeks or months. This is that new product. So this is in a late phase clinical trial. The company is hoping that it will get approved, that they'll prove it works and get approved by the FDA sometime soon. This takes an old topical steroid called halobetazole, which is a potent topical steroid, and combines it with the vitamin A derivative tazarotene. And the combination actually proves to be better than either product by itself. So that's something you can potentially look forward to in the near future. There's another class of topical agents based similar to there's an oral medication called a Pramolast or Otezla, which we'll discuss, and some companies are trying to use that in a topical preparation, so that may be another potential topical product coming out soon. When you have resistant areas on the skin, even if you have low surface involvement, if you have, again, troublesome areas like the scalp or the face or the palms or soles or genitals, or if you're getting into that more severe category where it's next to impossible to keep applying topical steroid over a large part of your body, you move on to systemic therapies. These are the older ones that in general tend to have more side effects. They're they're less targeted in the way they act. They tend to have broader immune implications. These are cyclosporin, methotrexate. Those are the primary two used for psoriasis. Sulfasalazine and 6-thioguanine are used by rheumatologists for arthritis. Primarily, they don't have much effect on the skin. Acitretin or soriatane is an oral form of vitamin A. And that one, if it does work, it can work well. It's not quite as effective as many of the other products. And again, the limitations of these, they have issues with potential liver issues on the methotrexate. The cyclosporin drug can raise blood pressure and cause kidney issues. They're good medications, and they can work in the right circumstance are used. But there are newer products that are probably getting closer to better safety and better efficacy. This is that oral systemic agent I mentioned. So this was the first new pill that was approved to treat psoriasis in decades. And so it's called a Pramilast. The product is called Otezla commercially. This is a twice daily pill, and it's sort of an anti-inflammatory approach. So it blocks an enzyme inside cells that causes inflammation. So it shifts the pattern of inflammation away from inflamed psoriatic skin, and can work well. It's tolerated very well. Has a slow improvement usually. If people are on this, I usually tell them your expectation should be improvement by 3 months, but your peak response may not be till 6 months of taking it or even longer. It's also approved to treat psoriatic arthritis, and it's a pricey medication, but it's often used by rheumatologists in conjunction with a biologic. So that's an exciting development. That's a new oral medication, and there are a couple of new, potentially new oral pills that are going to be coming out as well. We'll talk about later. And then the big category are these biologic drugs. These they're called biologics because they are protein molecules, essentially antibody molecules, like your immune system makes to fight off infections. But what these do is they block to specific targets, other specific proteins that signal the cells in your immune system to cause inflammation and then have an effect on the skin. So they're blocking the ability of this inflammation pathway to go, and by putting the brakes on that, they bring your level of inflammation hopefully back to normal and normalize your skin and joints. And so they've been around for a while, 15, 20 years. The earliest medications approved are etanercept or Enbrel, adalimumab or Humira, and infliximab or Remicade. This is a class called tumor necrosis factor alpha inhibitors or TNF inhibitors. That TNF protein is a very prominent inflammatory protein that drives a lot of inflammation. Again, you need that to protect yourself from infections and cancers. So there's good efficacy with these drugs. They can clear skin, upwards of 50 to 70% of the time in many individuals. They're well tolerated. The Enbrel and Humira are self-injections. They're they're more frequent than some of the newer products. Enbrel is given twice a week or once a week. Humira is every 2 weeks. Remicade is a unique drug. That one is given in the vein in an intravenous infusion, so you have to go into an office to do that. It's a little more flexible because you can give different amounts of it based on someone's weight, for instance, or how they respond to the medication, and that has better success rates. So most studies will show up to 80% or so of people can get clear on that drug. All three of these are great for psoriatic arthritis, and they're usually first or second line to treat that. to talk about pediatric psoriasis, just briefly, there's not a lot to talk about because, like most medications, it's very hard to get the FDA or a company to try and test medications in children because of the obvious concern with their young age and what the the effect of any medication might have on a changing body, growing body. So Enbrel actually has been approved now to treat moderate to severe psoriasis in children between the ages of 4 and 17. It's the first and only at this time approved medication systemically for children with psoriasis. It's been used for a long time with children with arthritis, and they've now done a 5-year follow-up study to show that there seems to be good tolerability and good response to the Enbrel in kids with psoriasis. So that's something to discuss with your dermatologist, your pediatrician. Ustekinumab or Stelara, which we'll touch on next, is it's likely to get approved. They're actually doing studies in children as we speak, and hopefully that will be another approved indication. I would say that just because these drugs are not tested or approved in children does not mean they cannot be used. And so that's always a discussion of the risks and benefits with your provider. But there's nothing to say that a child with plaque psoriasis won't respond to a newer medication like Cosentyx or Taltz or Stelara or Humira. You just need to have those discussions and weigh the risks and benefits. So this is the next category. Those TNF blockers have been around for, like I said, 15 years. They were the first to come out. The next step about 9 years ago was a different drug that blocks a different molecule. So this is the only drug in its class so far. It blocks these two proteins, IL-12 and IL-23. So you may hear people talk about it as it's an IL-12/23 inhibitor. So this is ustekinumab or Stelara, and it's a very effective drug. Again, you're in the 70-80% or so of people will get nearly clear skin. It's the unique one because it's given only every 3 months, so it's a very convenient 4-time-a-year dose. It has 2 available doses depending on your weight, so there's some flexibility if you're not quite doing well on one dose or such. And that was a very unique thing because it seems that this pathway of IL-23 is the primary inflammatory pathway that drives psoriasis. And so there are several drugs that are going to mimic this drug, hopefully coming out soon. And the 2 newest drugs, which we'll talk about, are just downstream of this. So they also block in this pathway. In the 9 or so years it's been on the market, there have been really no safety issues. So it looks like it's a very safe medication. And again, that's probably due to the fact that it's really targeting just this pathway of inflammation that's overactive in the skin. And so again, you have a very good, effective product that looks well tolerated. And these are the 3 products actually that are mimicking that Stelara. So these are not approved yet. There's potential that the guselkumab drug there in the center will get approved later this year or even late summer. And these are very similar to that Stelara drug. They block only the IL-23, not the 2 IL-12 and 23. And it seems like that's the real pathway that needs to be blocked. And they're having results of 80 or 90% of people getting clear skin. As you can see, the guselkumab at 4 months of using it, 86% of people with almost clear skin. So these are very targeted. Again, they look safe in early studies. So there's still hope that more and more products are coming along here. And then there's 2 others to talk about. So these are the newest that are approved already Both were approved within the last 2 years. And these are, again, they block a different protein called IL-17. There's a little slide that I'll show you to sort of visually describe this pathway. But this is an inflammation protein. It's a step ahead of the IL-23. And it directly does a lot of effect on the skin, causing the skin to grow and cause the psoriasis plaques. And so there are 2 drugs that inhibit just this protein. And currently they have the best efficacy results. Again, they're in the 80–90% of people getting clear skin. The one is called Cosentyx. It's approved for both arthritis as well as psoriasis. It's basically a self-injection every month. The other drug is called Taltz. Again, it's in trials to see if it works for psoriatic arthritis, approved for psoriasis already. And again, it's basically a once-a-month self-injection. And they have a very, again, good safety profile. There have been rare cases of people that develop bowel disease, Crohn's disease, or ulcerative colitis on these. So there may be a potential risk in people with a predisposition for those things. But again, very safe and incredibly effective. There's a third drug in this category which did get approved. It's not on the market yet. So you may not have heard of this. It's called Siliq, or the generic is brodalumab. This one also inhibits IL-17. It's a little different in the way it works, but has very similar results. This is it's basically more often. You have to give it every 2 weeks, and there's a caveat with this one that there is potentially a risk of depression or suicidal behavior or thoughts. Again, this is a very controversial area, but there is a warning about that, so it's something to keep in mind when you have a discussion about using that. Those are the approved and soon hopefully to be approved biologic shots. These are 2 new oral medications I talked about earlier. Again, these are not on the market, but they're in clinical studies. The tofacitinib, or Xeljanz, it is on the market for rheumatoid arthritis. It's in late-stage trials to try and see if it works for psoriatic arthritis. And then baricitinib, which doesn't even have a trade name yet, is also being studied. And these work differently than anything else. They go inside of the cell and block specific inflammatory signaling pathways again. So different than the Otezla, different than the biologics. So these are, again, different approaches that may give people other options. I'll take a few minutes here just to talk about some of the frequent questions that come up when people are using biologic medications. So the one is, do you ever need to stop your biologic, or what do you do if you do have to stop it? It's hard to tell patients if you ever need to stop these. We know that psoriasis and psoriatic arthritis are genetically determined. They're not something you can cure, but you certainly can treat them successfully, and they will go into remission, for various lengths of time. So if someone is doing well and they've had clear skin and their joints are feeling fine, it's hard to say, you want to avoid stopping them. I usually tell people if you do stop it, it's likely you'll get bad again at some point. There was concern with some of the earlier drugs that if you stop and start, that you will actually tend to lose the response over time. So it may work, excuse me, it may work the first time around, the second time around, but if you stop and start a third time, maybe it won't work as well. And that's a potential argument to say, well, you're better off just staying on these and not letting that loss of response develop with time. The other issue that can happen is people do really well on these, and after 2 or 3 years, they seem to lose their effect, despite the fact that they've continued to take them. And that's a tricky thing. It certainly happens, and there probably are a percentage of folks that need to switch between drugs. There is evidence that you can switch back to something that has worked in the past and then lost its effect if you've been off of that drug for a while. So some people talk about cycling back to something you've tried before. There's some discussion about if you're on a medication that's losing its effect, can you recapture that effect by adding a second drug? Classically, methotrexate pills are used for psoriatic arthritis by rheumatologists. So potentially using Otezla or methotrexate or even cyclosporin with a biologic to recapture the effect. Perhaps some of the newer oral medications will allow you to do this. Most people do well on the newer biologics and seem to maintain their effect over years. However, surgery is always a question. It's somewhat hard to answer. There aren't real hard and fast guidelines. Most of the time, if someone has a surgery planned, I tell them to have a discussion with the surgeon. If it's a major surgery, you usually want to be off of a biologic for at least 2 weeks before you have the surgery. If it's a longer-acting drug like Stelara, you probably my take is you want to try and be off of that, close to the 2 or 3 month window. So if you're going to get your Stelara, get your dose, and then wait right before you're due for your next one 3 months later and have your surgery, and just delay that next dose. And then I usually tell folks about 2 weeks after the surgery, when you're past the risk of mainly infection or other complications of the surgery, it's probably okay to restart that. Vaccinations, in general, if it's a live vaccine, it's not recommended that you receive it while you're on a biologic. That's primarily the shingles vaccine in adults. And rarely people, if you're going for a flu vaccine and you do the nasal mist or flu mist, that's another live vaccine. So those two are kind of the big ones to really avoid. If you're getting another vaccine, say a tetanus shot, again, they're probably safe. There's some concern that the vaccine won't work as well if you're on a biologic, but there's actually fairly emerging evidence that that's not a case. So getting your flu shot once a year is good. Pregnancy is another issue. It's, again, hard to give a hard and fast answer to that, but in general, we tend to discourage women from staying on systemic medications when they're trying to conceive or are pregnant. But having said that, if you have severe arthritis, you have severe psoriasis, many women stay on biologics and actually do fine through the whole pregnancy, conceive fine. So there's not a lot of published evidence that there's a risk to the fetus. There's always a caveat that we don't know, but in general, children have been born to mothers on biologics with no issues. But again, it's a complex thing, and it's a close discussion between you and whoever's prescribing the biologic and your obstetrician. And if you need to stop because of serious side effects, again, that's another. It's a tough thing to answer. But if you develop something on one biologic, it may be safe to do a different class of biologic that works differently. Mechanism of action is different. It may mean you want to return to an oral medication. So again, it's a very individual answer depending on the situation. We tried to capture in one slide where these biologic medications work, and unfortunately, these are always very, very complex. I'll just show you quickly. This is a schematic of your skin. Here's the base of the skin. This is the psoriatic plaque with all this excess skin cells piling up on themselves. And then underneath, these are the immune cells. So there's a cell called a dendritic cell, and these are helper T cells. And the way I like to think of this thing is basically this is where the inflammation starts. IL-23, and this is the drug that Stelara blocks. And if you can imagine, here's an antibody molecule like Stelara blocking it, binding to it. And these newer IL-23 blockers, they prevent this protein from telling this cell to do its thing. This cell, the helper T cell which produces IL-17, it's a little hard to see under here, but it's called a Th17 cell because it makes IL-17. Again, the drug Cosentyx and Taltz, secukinumab, ixekizumab, those two block the product, this IL-17 that it makes, and so then this thing can't hit the skin cells and have them do their thing. And again, so that's primarily where these newer biologic drugs are working. The older TNF inhibitors, this TNF protein, it's produced actually by probably every cell type here. So whenever there's this inflammatory signal, you get a lot of tumor necrosis factor alpha produced. And so that's why when you block it, it probably has a broader effect, not only on the skin immune system, but other areas, and which is why there's again a little potential for more risk with these older biologics. Kind of glance at that for a second. So this is a brief slide on how do you think about treating or not treating. And so with any medication, or any intervention, it's always a discussion about what's the risk versus the benefit. And if the benefit is greatly outweighing the risk, it's maybe worth using that. So one of the things we'll touch on is we're starting to realize that when you have a lot of uncontrolled psoriasis, the inflammation in the skin actually is trickling over, and you have inflammation elsewhere, including in the large vessels of the heart, and you may be at risk for heart attack and other cardiovascular disease. And so if you don't treat it, you may put yourself at risk for other health issues. Same with the psoriatic arthritis. Fear of side effects. So again, that's if you're, in terms of risk of not treating, if there certainly needs to be discussion about side effects, but if you're overly concerned, it may lead you not to treat when you could successfully be treating. Same with not treating due to the, there's a huge impact on your psyche, and if you're not addressing the psoriasis, your mental health can suffer too. And the benefits again are the opposite of these: that you can improve your quality of life, you can get better overall health perhaps with some of these medications, reduce inflammation. So the two primary comorbidities or other things that go along with psoriasis. One is the psoriatic arthritis. But the one that's becoming more and more obvious to researchers and providers now is that if you have severe psoriasis, and usually, especially above 10% of your body surface area involved, it does translate to systemic inflammation. And the inflammation that drives the skin psoriasis also causes atherosclerosis, or hardening the arteries, and you put yourself at higher risk for having a heart attack, stroke. And so just like if you're overweight or you have high blood pressure or you're a diabetic, if you have bad psoriasis, that's another risk factor for heart disease. And so that's another thing to be cognizant of in terms of modifying your risk of having a heart attack. It's not enough just to lose the weight and try and control your blood pressure. You actually have to treat your skin too. And this may start when the body surface area involved is even lower. It's not as clear cut, and if you have very limited disease on your elbows and knees, say, you may have very little risk overall. But in general, this is something to really discuss with not only a dermatologist, but with a primary care provider and say, you know what, I need to do something more about my skin because this is also contributing to my potential overall health. It hasn't been shown quite yet that actually treating can reduce this risk. That's a hard thing to prove. It takes years of studies because these are still rare events. But there are several ongoing studies trying to show that, especially with some of the biologic medications, that you can reverse this risk. Psoriatic arthritis is the other large one. So roughly a third, maybe a quarter to a third of people with skin psoriasis will develop psoriatic arthritis. It's a potential debilitating arthritis. It can cause permanent joint deformity. But again, if you develop it, it doesn't mean you're going to have severe psoriatic arthritis. Just like your skin may not be severe, the joints may not be severely involved. So there's a lot of ways to treat that. And the good thing is, in general, the treatments that work for arthritis will work for the skin and vice versa. So for the most part, you can treat these successfully with single medications or combinations. And again, we know that having, these are these other metabolic risks are called. So again, having psoriasis, patients with it tend to have higher metabolic issues in general, so higher incidence of high cholesterol and type 2 diabetes and high blood pressure. We know that depression is higher, in patients with psoriasis than in the general population, and it's a complex thing and something that needs to not be poo-pooed, needs to be addressed. And again, there are good outcome studies through the NPF has published these even showing that treating your skin can improve your overall health, your mood too. And then the last category there is inflammatory bowel disease. So as I was mentioning, those IL-17 blockers seem to have a potential rare risk of bowel disease as a complication. It's a complex issue because if you have psoriasis in general, you're actually at higher risk to have Crohn's disease and ulcerative colitis because the genetic pathways overlap a bit. So that's another thing to think about if you have psoriasis and you start to develop gut symptoms such as diarrhea that's not explained or doesn't or lingers or crampy abdominal pain. That's something to bring up with your provider. Okay, and we'll wrap it up now. We're talking a little bit about lifestyle and diet modifications. So when you talk with your provider, you should always be an active member of that team. You should think of this as a team. I think it's a two-way discussion about how to get your overall health improved, how to reach your target goals, and ensure you have the best outcomes. So it should be based on choices, should be based on different options, and talking. And basically, this should be a two-way discussion. And if you don't understand that or you don't feel like you're getting the right answers, I think it's always appropriate to get a second opinion. Because, again, this is your health. What we usually like to see as a physician is that you take an active part in your appointment, and that usually means coming prepared with questions and your concerns. It often helps to prioritize things because the encounter your appointment may be limited in time, and it may take an extended appointment or a return visit to hit all your questions. And then through groups like the NPF, if you can stay informed about your own disease and actually potentially come in with some goals and some options that you've researched and you want to know about, that can be very helpful. Insurance benefits, they always seem to play a role these days, so potentially talking to your insurance plan about what options for psoriasis are covered and if there are any requirements you have to fail a certain medication or a certain medication or two before you get approved for something. Potentially knowing what your copay or your co-insurance will be, those things can help. And with any medical encounter, having a list of your medications and doses is always important. Other physicians or providers that need to be discussed, having their names. And then it's good to be specific. you want to you want to be direct. You want to be quick and clear in your report of your symptoms, and it's nice to know a timeline. So when did you first have these issues? So having a date in mind, a timeline, knowing what you've tried in the past and if it's worked or not. Discussing how your skin affects your overall health. Those are good. You always have to be honest. So it doesn't help to minimize how much you drink, for instance, or minimize the effect on your mental health that your skin disease has. It's a confidential, personal interaction with your physician. You should be upfront. And there could be a reason that you're experiencing things which someone can help with if you bring them up. So these are, not have to read all these. These are some of the things you can ask. So how severe is it? What are my options? What are the side effects? How quickly can I improve? Do I need tests or not? Is there anything tests I need to do before I start it? What are my other options? So again, basically being proactive helps. Psoriasis and psoriatic arthritis are notorious for starting with different triggers. The triggers are unique for every individual. There may be multiple triggers. There may be different triggers at different times of your life. And it's really hard to tie these down. But if you can get a diary going of what seems to trigger, predispose a flare of your skin or your joint inflammation, that can sometimes be helpful, and perhaps in helping you avoid things. I'll throw out smoking as one. Many patients that have palm and sole, especially pustular psoriasis, seem to be heavier smokers, and even decreasing the amount of tobacco use or quitting can improve your skin just by itself. Stress is always blamed for a lot of things, and it certainly plays a role in health. The more stressed you are, you get an overactive immune system. That can certainly cause flares of psoriasis, and it's been shown that meditation or other mindfulness exercises can actually improve skin disease too. So reducing stress can help. And these may or may not be obvious, but there are many signs of stress: trouble sleeping, lack of energy, nervousness, feeling overwhelmed, feeling underwhelmed, apathetic about things, losing interest, decreased contact with family or friends. And again, it's impossible to avoid stress, obviously, but you can make it a priority to try and minimize its effect on your life. Saying if you're someone who always feels they have to say yes, you may need to step back and say no to some things and reduce your stress level that way. Quality sleep's always important. Making sure your medication is taken at the right time of day, for instance, that can help. Again, regular support from others, your provider, and exercise in general not only helps you lose weight but reduces stress. So this is about nutrition. So it would be wonderful if we had an answer for how you can change diet and improve skin and joint disease. And if you skip to the very bottom, the basic answer to sum up all the evidence is that there's no clear answer. So there are certain individuals who can reliably report flares of their skin or joints with certain foods. But if you try and systematically study that, there's not a robust amount of evidence showing that there's any clear trigger. So again, this may be a somewhat individual approach. In general, a balanced diet, and in fact, something similar to a Mediterranean diet, is thought to involve mainly, kind of low inflammation or anti-inflammatory properties. And the opposite is true if you eat simple carbohydrates and saturated fats, that those tend to be more inflammatory, pro-inflammatory. And so in general, if you're talking about skin disease and and overall health as well, increasing the amount of good fats or unsaturated fats for its omega-3 fatty acids of fish oils, olive oils, avocado, the amount of nuts you eat, fruits and vegetables and whole grains, and getting rid of refined simple sugars and carbohydrates, saturated fats, and in particular trans fats. Heavy alcohol use for sure tends to cause more inflammation and can make psoriasis worse. And here's an example of what's called the classic Mediterranean diet. And basically, this is rich in those healthy and less inflammatory foods, so vegetables and fruits, and beans, grains, chicken and fish. And these have been shown to affect cardiovascular health in general. There's some big proponents of what's considered an anti-inflammatory diet. This is up there you can peruse, but it's basically that following what's considered a Mediterranean diet. I can say two more things on nutrition. So I think the best evidence out there exists for fish oils. So there are fairly well done studies showing that omega-3 fatty acids, again, not only can improve cardiovascular health, but probably can improve, many different inflammatory issues on the skin. So I've certainly had patients who their skin improves. And the other one is turmeric. So turmeric has been used for, again, decades, or centuries or millennia. It's been used for a long time, and it's thought to have anti-inflammatory properties. The problem with that is you don't know how much you need to eat on a given day, so both of those things. I definitely have people who say their skin has improved. I have a hard time recalling anyone who said their skin has completely cleared just by adding turmeric to their diet or changing their overall diet. But I think these are things that can certainly help, and it's not a bad idea to try. So overall, the summary slide here. This is we basically say that working in partnership with your dermatologist or other provider is good. Keep in mind these treat to target goals. And again, this is not a rigid guideline, but it's a way to start bringing up the discussion. And good communication is obviously a key. Eat to promote health and not disease. Make lifestyle changes that improve your overall health. And then whatever you do, don't let this define you. Take charge of it and realize there are very good and safe treatment options these days, and you shouldn't have to just keep dealing with it.
Great. Thank you so much, Dr. East. We'll now move into our question and answer portion of the webcast. So first question here, could you please talk about the evolution of scalp psoriasis through time, how to avoid it worsening?
Well, okay, so scalp psoriasis is a notoriously tough thing to treat, and it's obviously an awful thing to deal with. The progression over time, I think, is, again, an individual thing. Many people have scalp involvement when they have classic plaque psoriasis on the elbows and knees, for instance. And we certainly also see a good percentage of people that have primarily scalp involvement. That's their only real troublesome area. The progression, I think, is, again, it's an individual thing. It tends, in my opinion, it tends to be a very persistent aspect of psoriasis. I think it's less likely to go into remission. And some of that is it's an area where you rub and you scratch, which sort of likes to excite psoriasis. And treating it's difficult because it's hard to get anything onto your scalp because the hair is not the problem, it's the scalp. Most of the most effective treatment, I think, is usually a topical high potency steroid, such as clobetasol or betamethasone. And they come in liquid forms, which improve the way they can get onto the scalp. It's easier to apply them. There's also a scalp oil that can work well in some people if they don't mind the oiliness. One of the vitamin D derivatives also comes in a solution, and So combining that with the topical steroid can be a good combination. I like the excimer laser as well for treatment of scalp psoriasis. You have to find a dermatologist that has it and commit to the time it takes to do that, but that's another good way. Ultimately, I think it's difficult, and oftentimes we end up using oral or biologic medications for the scalp.
Great, thank you. Next question here. I developed von Zumbusch psoriasis after use of a beclomethasone steroid injectable. What are my treatment options?
So von Zumbusch psoriasis it's a widespread pustular form of psoriasis. Horrible. And one of the triggers that's fairly often reported in the literature is that it was someone that was receiving either oral, intravenous, or subcutaneous or intramuscular steroid injections. And for so steroids, when you put them in the skin, they get rid of psoriasis beautifully. If you take them by mouth or by IV, it works as well because steroids shut down all the inflammation in the body. But this rebound phenomenon where you can develop worsening psoriasis or even these pustular variants does happen when you do that. So we always caution people if someone wants to start you on an oral steroid or give you injections to be cautious if you're treating psoriasis because it can get worse and flare. The treatment options, in general, besides avoiding repeated injections of that steroid, you have to treat it systemically. Usually, I actually usually use methotrexate. It can work very well for pustular disease. Cyclosporin works as well and can work quickly. The biologic medications also work well. It's a question of how quickly can you get those and the cost.
Great. Next question here. What are the treatment goals for topical therapies, and what is the expected time to see results with topical treatments?
So I think there shouldn't really be a difference in how you think about treatment goals. If you're using a topical or light therapy or a biologic, the goal should still be, in my mind, is near complete clearance or complete clearance of a plaque of psoriasis. Again, if it's a strong topical steroid like clobetasol or betamethasone, you're going to hopefully see improvement in 2 to 3 weeks. So they can work fairly quickly. The lower potency topical steroids will take longer. The alternatives like the vitamin D and vitamin A derivatives also are slower. But again, by 3 months of use, you should be reevaluated and saying, is this something that's keeping me clear? Does it work, but I have to continue to use it every day because if I stop, it comes right back. And if that's the case, it may be time to think about something different.
Great. Next question here. I've failed 3 biologic medications. Is it possible that I could have a misdiagnosis?
That's a great question. I guess my answer is yes, potentially so. Again, these newer biologics, the IL-12 and 23 inhibitors, the IL-17 blockers, they're pretty active, again, for most people with psoriasis. And so if you've failed, a biologic in both of those classes and a TNF blocker as well, I think I would probably question the diagnosis. It's not to say that you don't have psoriasis. For one example is in particular, if you have Palm-and-Sol disease or you have especially Palm-and-Sol pustular disease or other pustular disease, those are notoriously difficult even with the biologics to treat. So it's never a bad idea to question your response, and it may be that's the type of time it may have helped to get a skin biopsy done on the areas of what's presumably been psoriasis and make sure either you had something different to begin with, or you've developed something that is no longer psoriasis too.
Great. My next question here, my level of psoriasis has been the same for 50 years, and all of a sudden it started expanding. What could cause this expansion, and can it be stopped?
So that's another, $100 million question. So presumably there has whatever the trigger is for your particular form of psoriasis, something has changed. So one of the examples is you start a new medication. So your disease has been fine, and then you start a new medication, and all of a sudden it triggers worsening. It could be a major stressful event, so a death of a family member, that can all of a sudden cause your psoriasis to change its pattern. So there isn't often, sometimes there's an identifiable thing, but I see a lot of people who have had very stable, well-controlled psoriasis, and for no good reason it seems to take off. We know in general as you age, the immune system functions differently, and it may be that it's just a part of the natural aging process, and unfortunately that happens, and it may be something, if it's a temporary flare, that you can treat that successfully and you'll go back to your old pattern. Hopefully that's the case.
Thank you. Next question here, is it safe to combine an oral treatment such as Otezla with a biologic treatment such as Taltz?
Okay, so again, it's hard to talk about safety, in particular because, again, everybody's individual. So depending on what your other overall health is. To my knowledge, I don't know of any studies that have been controlled well showing use of both Otezla and a biologic, or actually Otezla and potentially anything else. There may have been use of Otezla and methotrexate combined in some of the arthritis trials. However, that does not mean it's not safe. And as I was saying, I've encountered a good handful of patients who rheumatologists have been prescribing a biologic plus Otezla. So again, I think it's used and it can be safe, but I think you have to think about, is it potentially adding more risk because you're blocking more pathways.
Great, thank you. Next question here. When you're on a biologic, does this mean that inflammation factors like C reactive protein would go down?
The answer is usually yes. Especially if you have psoriatic arthritis, we know that markers such as CRP levels do go down. In terms of skin psoriasis, it's interesting because there doesn't often seem to be a correlation with the level of your CRP elevation or your sedimentation rate elevation and the amount of skin disease you have, or necessarily a response to medication. So I think that it may be getting at, is there a blood marker or something that you could follow over time to see if a medication's working or not. And in terms of skin psoriasis, we haven't found a good one yet.
Is there a risk to vision from any of the biologic drugs?
I don't know of any package insert on a biologic that talks about a risk of vision directly. There are rare reports of inflammation of the optic nerve, optic neuritis, that have been reported, especially on some of the old TNF inhibitors, the older drugs. They've had some neurologic side effects. But nothing direct, nothing that would necessarily worry me.
Great. You indicated that controlling psoriasis perhaps controls associated comorbidities. Is the reverse true as well, such as if you control your diabetes, will your skin get better as well?
I think the answer to that is yes and no. Probably the best evidence exists if you lose weight. So if you're overweight and you lose weight, not only does that tend to improve your sugars and your blood pressure, but that can improve your skin. And that's been shown with people that have undergone bariatric surgery, for instance, and getting dramatic improvement in their skin psoriasis. Alcohol use has also been shown. If you are a heavy drinker, oftentimes decreasing the amount of alcohol intake or quitting can make your skin improve or easier to treat. But I don't know if I'm trying to give a direct relationship where controlling your diabetes better tends to help your skin. So there's a yes and no to that.
When should a primary provider refer a patient to a dermatologist when it comes to psoriasis?
Depends on the primary provider. So physicians are all trained extensively, and then pick up different amounts of knowledge over the years of practice. And so if it's someone who's worked closely with a dermatologist or has had excess training or is comfortable doing I think it's those providers can treat you very well. So some of it's how involved they are. Again, I think if you're not reaching a treatment goal, that's the time to say maybe I need to see a dermatologist. I would think you keep that in mind. If you bring up questions that the primary provider isn't able to answer, again, that's a time maybe a consultation would be helpful.
How do you treat peristomal psoriasis?
Again, that's a tough thing. We usually start with strong topical steroid. So I usually use a class 1 clobetasol or halobetazole or betamethasone. There's an immunomodulator topical product called Protopic or tacrolimus that can work for peristomal disease. But other than that, it's the same algorithm. If it's not responding, it's something that certainly can respond to oral medications or biologics.
Great. And we have time for one last question here. Can you combine biologics with topicals?
Certainly. In fact, many of the, not many, but yes, they've been used even in the clinical trials. So the answer is, if you are doing wonderfully, but you have a little bit of psoriasis left, certainly, we'll usually first line try and treat it with a topical and see if we can clear it up completely. So yeah, light therapy is the same. If it's a narrowband eczema or laser, for instance, again, I think it's a great thing to add to a biologic.
Great. Well, thank you so much for sharing your expertise with us, Dr. East. And if you have any other questions, please contact our Patient Navigation Center by phone, email, live chat, or Skype. We also have many resources available to you that you can see now on the screen. We would also like to highlight our Psoriasis 1-to-1 program that connects you to trained volunteers that have psoriatic disease and can truly understand what life with psoriasis and psoriatic arthritis is like. Once you leave today's webinar, you will receive a survey on the presentation, and we'd appreciate if you would complete that and provide your feedback. Finally, I just want to mention that a recording of tonight's webcast will be available shortly on our website, and you can access our complete webcast archive by visiting www.psoriasis.org/webcast. Thank you to everyone for joining us tonight, and have a lovely evening.